Everyone. So let me start by asking a question. How many of you have visited a dentist in the last 6 months? Okay, so those of you who did not put your hand up, you are not retained in dental care. According to the American Dental Association periodicity of dental care, you need to see a dentist every 6 months. And therefore you're not retained. I can tell in this room the retention rate was about 50%. So think about that when we get to our patients, okay? So everybody knows that in order to succeed in antiretroviral therapy, we got to diagnose patients, we got to link them to care, we have to retain them in care, start them on antiretroviral therapy, work in adherence, and then we're all happy. And this entire process is called engagement. And this process of engagement is something that I think in the last couple of years we've been learning more and more about. Because we focused a lot on how many people we start on therapy, how many people we get on therapy, how many people we test, but we really haven't been looking much longitudinally until very recently. So this is the data that Ed Gardner and I and several others put together out some years ago, and I'm not going to focus on the data right now, because you could argue anything you want, but the reality is I'm going to focus on this part. And I would tell you that I think we're doing quite well in linkage. I'll talk a little bit about linkage, but where we're really not doing very well is in retention. We lose a lot of people as we move forward, and therefore, and retention is critical in achieving virological suppression. So I want to get you encouraged and get you thinking that really retention is something we need to worry about. And as you saw from the example from dental care, it's a big issue, and it's something that really we all need to understand more about. I also want to emphasize that currently we have on antiretroviral therapy in the United States probably around 300,000 individuals. And yesterday I was listening and hearing, oh, we need to put 90% of people in antiretroviral therapy. Well, that in the US would mean getting about another 850,000 or so people on therapy to get 90% coverage. And I can tell you, we cannot do that right now. So it's very hard for us to ask the rest of the world to do that if we can't do it in our own country. So there's a National AIDS strategy, and the National AIDS strategy actually looks at this. And the National AIDS strategy in the US said that by 2015 we're going to increase testing and people who know their serostatus from 79% to 90%, and we're doing fairly well. We're moving in that direction, not quite there, but we're moving in that direction. A lot of testing is happening. Linkage to care is also going to increase. Within 3 months of diagnosis, we're going to link. We were at 65% of newly diagnosed individuals. We're going to take it up to 85%. We're pretty close to that. Now, retention in the National AIDS strategy was just limited to Ryan White clients, and the reason for that is because in the non-healthcare system existing in the United States, you really have no idea who's retaining care nationally. Kaiser may be able to tell you, the VA may be able to tell you, but outside of those healthcare systems, nobody knows what's going on. And the only data the government has was Ryan White, but Ryan White, the idea was to link it to 80%, and finally increase the proportion virally suppressed by only 20% more. So we were at 25%, get it up to about 30% or somewhere around there. So again, not very lofty goals. Now, I want to show this because this is a graph that when Ed Gardner and I wrote the paper, we did this modeling on what would happen if you got, this is the current situation on bar A, and we said, okay, if we got 90% of people in the US diagnosed, and we got 90% engaged in care, and we treated 90%, and we got virologically suppressed 90%, you would probably get about 66% of the population to undetectable. So even doing very, very well, that's about where you get. And I want to emphasize that because, again, there's still a lot of people up here who are not going to be doing very well, even in a very well-running system. And clearly that is a big challenge because it's very hard to even get to those numbers. So a couple of years ago, the Institute of Medicine was asked by the National Office of AIDS Policy of the White House to try to give us some measures of linkage, retention, and viral suppression. And the whole idea is, we need to know what to measure so we can know what the goals of the National AIDS strategy have been achieved or not. And a series of core indicators were made. There's a reference. You can download the book. There's actually 2 books that were put together. I'm not going to go into the details, but basically a series of core indicators were made. Secretary of Health and Human Services in the US put out their own core indicators based on this, but they're a little different. And in fact, Ryan White and HRSA have their own indicators. And this is important. I just mentioned it is because I'm going to present a couple of data from CROI in which you're going to see that these are a little different, depends which indicator you're looking at. So even in the US right now, we have 3 indicators. There's the IOM indicator, there's the DHHS indicators, and there's the HRSA indicators, and they're not the same. Okay, so linkage to care. The IOM, we agreed that link within 3 months of diagnosis was the goal. The only randomized trial of an intervention to increase linkage to care that has been done is called ARTAS, and this was a study that we published back in 2005 in which we took participants in 4 cities newly diagnosed with HIV, or at least newly diagnosed within 6 months of of diagnosis, which were more likely to enter care if they were within 6 months of diagnosis. And we gave them up to 90 days of strengths-based case management. And compared to controls, you clearly got a better linkage and a better retention in care in 6 and 12 months. Older clients, those with much outside help, and non-crack users were more likely to benefit from the intervention. This study, which was effectiveness study, was replicated by CDC in R-TEST2, which was an efficacy study working at health department levels, and it was shown to be effective. So now this is considered best practice. Retention and care. So retention, I'm going to use the IOM definition: proportion and continuous care, 2 or more visits in the preceding 12 months, at least 3 months apart. So if you go to care, like in a calendar year, you go to care in May and in August, you count as being retained that year. You go to care in June and July, you're not counted as being retained because those 2 visits are too close to each other. We know retention is critical. It predicts virological suppression. But there are a couple caveats. There's really not a great way to measure retention. I told you about the 3 different indicators, and there are more. WHO has their own, etc. We really don't know much about who exactly is lost to care, and in fact what you're going to find, and what we found in several studies, is we think somebody's lost to care, and when you find them, in fact they're in care somewhere else. People move from care facility to care facility. We really don't have a good tool to predict who's going to be not retained in care. You know, a lot of studies say, well, you know, African Americans, poor, uninsured, are less likely to be retained in care. Well, my clinic director, Dr. Wendy Armstrong, says if that was the case, nobody in my clinic would be retained, yet our virologic suppression rate is about 70%. So obviously there are a lot of people who are poor, who are uninsured, who don't have transportation, who are still doing well. So we need to understand what is it beyond those indicators. I think those indicators are not necessarily telling us all the story. And there's really no intervention that have proven to be effective in retention. Contrary to ARTIS, which is a randomized controlled trial, there's really very little, and I'll show you the little there is in retention. So here's data presented by Rupali Doshi from last year at CROI, from the Ryan White funded programs in the United States. And you can see that if you were retained in medical care according to the retention definition of Ryan White, you are more likely to be virologically suppressed than when you're not retained in medical care. So obviously, again, trying to emphasize that retention makes a difference in virologic suppression. Okay, so I told you there's no gold standard. Mike Mugavero put this paper trying to say, well, here's common things: missed visits, appointment adherence, blah, 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 blah. And there's a series of different ways you can measure it. And it's really hard because a program needs to know what they're going to measure. They need to be able to look at this. Tom Giordano similarly put together this table, and look, you can look at the reference there. You can take a look at it. Each one of those, it's complicated, and each one of them has a lot of potentials for misinterpretation. And really, what kind of data do you need to be able? Is it easy to get, or is it really difficult to get at a program level? So this past year in CROI, there were a couple of interesting articles, and I hope you understand, a couple of interesting presentations, and I hope they're useful to you. So the NIA cohort looked at among 22,000 participants. 75% met the DHHS measure of adherence, 90% the HRSA measure of adherence. 85% did not show a 6-month gap in care. 84% had a CD4 count greater than 200, and 54 had a viral load less than 200. The DHHS measure was the strongest predictor of both having a CD4 over 200 and a viral load under 200. So they thought in that study that that was the best of all the retention measures. Mike Mugavero also presented at CROI some interesting data from the Scenics cohort. And here again you can see about this 3,000 and so participants, 64% met the IOM definition, 59% the DHHS definition. 32% had 0 missed visits following IRT initiation. You can look at this number, 8.5% died during follow-up, and that's a big issue. If you have a high mortality, your retention is not going to look that good because it's really hard to retain dead people. So if you if you have very high mortality because you're diagnosing people very late, and mortality is high in the first year, your retention rates are going to look good. And the way you need to approach it is you actually need to decrease mortality. You need to diagnose earlier in order to increase retention. It's not doing a retention intervention, it's doing a testing and linkage to care intervention that is going to improve your retention. But here you can see that failure to achieve the IOM indicator, the DHHS indicator, and missed visits were all associated with increased mortality. And increased mortality risk was higher among patients that had missed visits. And look at this Kaplan-Meier curve. Here's people that had 0 no-show visits. Here's people that had missed 1 to 2 visits. And here's people that had missed greater than 2 visits. And this is survival. So there was a higher mortality in people that missed even 1 visit. What is the message here? The take-home message is, as clinicians, Missed visits are clinically relevant, and they're actionable events with prognostic value beyond the core indicators of retention and care. So while my clinic may be reporting to the health department or to CDC or to WHO, my retention and care measures, the reality is at the clinic level, the clinician himself or the clinic administrator can look at missed visits and action among them. When a patient misses a visit, we ought to contact that patient and find out what's going on, because that is a really good indicator of actually mortality. We really need to look at that as a high-risk population. Finally, this other abstract that Croy I thought was interesting, again saying, are we focusing on the wrong indicator? 10% of patients who met all the retention criteria who did not meet the retention criteria were on antiretroviral therapy and virologically suppressed. We all have patients like this, and in fact, the year before, Michael Horberg presented the Kaiser Permanente data. Here's their cascade of care. Remember I told you you've got a healthcare system and you're doing real well, 60% suppression, 66? This is what they get, 61% suppression rate. But if they look at people who were virologically suppressed, who did not, independent of not meeting their prior stage. In other words, these people were not retained, yet of their entire population, 80% are suppressed. So again, maybe we don't need to measure retention. Maybe we need to focus on virologic suppression and forget about retention, because it's really hard to measure. Virologic suppression is really easy to measure, and at the end of the day, that's what matters. So this is some data, again, from a study that we did, and I'll try to walk you through this. This is regular attenders. These are people that come to our clinic regularly, don't miss a visit. These are regular attenders. These are the people that I call the whales. You know, you see them in the clinic when they're sick or something is going on, they need something, and then they disappear into the depths on the inner city, and you don't see them for quite a while, and then all of a sudden they surface again a year later. You know, those are regular attenders. And finally, these are not attenders, people that came to clinic once and disappeared. When we found those individuals, look at all the, in blue are our outpatient facilities, in blue are inpatients, and red are outpatient facilities in the city. The other way around, this is red is inpatient, blue is outpatient. You can see that those patients were shopping, going to many different facilities. And again, we don't have that data. So I can think that this patient is out of care when in fact this patient is in care. It doesn't matter if they're in care in my institution, they're virologically suppressed. So that brings me to a term that I want to introduce you. The term is churn. Churn was an epidemiological term introduced in 2009 by Gill and Krentz. It talks about patients circling in and out of care. And you see, you here have your active HIV population. Some patients move out of the region. Some patients just simply are circling in and out of care. That's called churn. So churn is a gap in care greater than 365 days, but returning to the same clinic. This is some preliminary data from patients that entered our clinic, one of our clinics in 2010. You know, so 242 patients, 31% of them churned. When they churned, when they disappeared, 17 patients were undetectable and 14 patients had detectable viremia. When they returned to clinic a year later, to the same clinic, we lost them for a year. They came back. Of those that were undetectable, 11 were still undetectable. They had moved somewhere else. They had decided not to come for a year, but they were still taking their medications. They were getting refills. And 6, unfortunately, were now viremic. And of those that were viremic, almost everybody was viremic. So the point here is when you lose a patient who's undetectable, it's very likely that they will be undetectable. But if you lose a patient who is detectable, it's very likely that they will continue to be detectable. So again, focusing on viremia, really important to look at this thing of churn. What about disengagement in HIV care in other countries? What do we know from Africa? Well, this is really interesting because my data in the US is beginning to look like this. There's a two-hit hypothesis. There's an unintentional reason for missing the clinic, and there's an intentional reason to missing the visit. Two things kind of occur together. And when those two happen, then there's a reluctance to return to care. There's weakening sense of connectedness to care, and then you get disengaged. So this process, and as a patient explained to me, you know, I used to come to clinic regularly, then my mom died. That's the unintentional reason for missing a visit. Then I couldn't get transportation, I couldn't schedule an appointment, so that was an intentional reason. And then he was reluctant to come back to care, he got busy, got other things to do, and eventually he disengaged. So again, it's not as simple as just saying, oh, the risk factor is being black or the risk factor is being poor. There's multiple things happening that make our patients disengage from care. So one intervention that has been done for increasing retention in care, a really simple one, 6 HIV primary care clinics, they look at pre-intervention and post-intervention. By doing this intervention, clinic attendance improves 7% over the intervention period, statistically significant but clinically not very relevant. But this is what they did, it's something really simple. They gave people a brochure. They just said, please come back to clinic. That was a very simple intervention. I think we can all do that. Just tell people that, thank you, continue coming to our clinic. Engagement in care is important because it actually not only, if you get people on antiretroviral therapy, you decrease risk behaviors. Just by being in care, you decrease risk behavior. And this is data from Lisa Metch and myself showing that people that are engaged in care are less likely to engage in unprotected anal intercourse. Okay, so challenges, in retention. One of the challenges is we don't have enough clinic space. We don't have enough way to see all these patients. People have complex lives. I think you have a series of toolbox in your interventions. We need to increase substance abuse treatment. We need to use patient navigators. We can use contingency management. And I just want to tell you, to end this Project HOPE is a study that we're doing. It's a NIDA-funded study in which we're testing patient navigator, contingency management, and treatment as usual because there's no randomized trials showing how these 3 interventions work and what should be done. And we'll have data from this study about a year from now that hopefully we'll be able to share at this meeting. So at the end of the day, it's very hard to know what to do. If you look at the guidelines on retention and linkage to care, you will see that basically not a lot being said about what to do. Patient navigators are at level C intervention, texting, etc. So we really don't have a lot of data, and we need to focus on that. And my message is, think about retention, think about re-engagement, and we need better studies to know really what works and what matters. Thank you.